All right. Hi, everybody. My name is Dr. Abdul Kone, and thank you so much, Your Highness, Dr. Tyson Pilo, for introducing me and for helping me with this. Today we want to talk about the most important topic in medicine, which is pain. Okay? Because we want no pain left behind. The goal is to achieve adequate and equitable pain management in the emergency room. Okay? Fortunately for you and unfortunately for us, we have no financial disclosures yet. All right, this is me without my beard in military medical school back in the day. I actually drew this. I drew this picture, without erasing in one shot. Turns out it's a very useless skill. So from my time in this international military medical school in West Africa, where cancer, untreated cancer, mistreated cancer, sickle cell disease are rampant, right? Seeing my patients, my relatives, living and dying at a young age from cancer or sickle cell disease, to working with the Hem-Onc department at Howard University Hospital, which is basically sickle cell central, right? To then publishing at the National Institute of Health on sickle cell disease, stem cell transplantation, and gene therapy, to my own experience, my personal experience dealing with the unremitting pain of my father battling metastatic prostate cancer. It's been a journey. It's been a long journey to building this expertise on the matter and helping painful aspects of these diseases while other people take care of curing the disease, right? Pain is terrible. Pain is debilitating, and frankly, a lot of people don't care about being sick. They care about being in pain. So this is what I want to do in my life. I want to be a pain doctor. I'm actually interviewing to be a pain doctor. I have actually an interview in the morning. Hopefully that goes well. So look at me with this baggage and this knowledge and this enthusiasm going into the emergency room to save the world. But I got slapped by reality, because a lot of us down there, and a lot of us, when our patients look a certain way, or when they have sickle cell disease, they are drug seeking until proven otherwise. That was a shock, but it hurt as well. It hurt because imagine my father going to the emergency room, or one of your loved ones going to the emergency room in desperate need of pain relief, and then we fail to provide this adequate pain medicine. It causes this feeling of helplessness. Like, where am I supposed to go? Right? So look at me going through these papers on disparities and interviewing pain specialists, anybody that has to do with pain. I'm interviewing them, and I come to a few conclusions. That we are smart. We have a lot of smart people. And second, pain management, there's so much more we can do when it comes to pain management, so much more. And I believe that we can, we will, and we must. Right? The matter is 75% of ED visits are pain related. So this is our problem. It is our problem, and it's a big one, right? While patients are desperately coming to the emergency room to get pain medicine, pain relief, we know that some populations have had less success at receiving pain medicine. There's documented racial and ethnic disparities when it comes to pain medicine. So this is us just bringing this conversation today so we can come up with a good plan to remedy the problem. In this discussion, we will show the evidence of these disparities. We will discuss the impact that this has, and we will model a framework on how to mitigate these disparities. We'll go through a few cases, and hopefully by the end of this talk, we will reach the promised land. So first case, 34-year-old female accompanied by her boyfriend. She comes in with fingers and knees pain, 10 out of 10. You come into the room, the patient looks terrible. She's in a lot of pain, she's crying. She has some swelling fingers and tenderness in her joints. The couple that tells you that they're out of town and they're here only for the weekend. She takes Norco 5 at baseline, but this is worse than her baseline lupus pain. She has lupus. Now, by show of hands, who here will not give this woman IV pain medicine? Right? I know that some of us will even interrupt the encounter, go order pain medicine before we complete the encounter, right? Because this is what we do, right? Now, if you notice, I did not share the race of this patient, right? She could have been Asian, she could have been white, she could have been Hispanic, she could have been black, right? But most of us guessed her race. Race comes in the back of our mind, which is a normal thing, which is normal, which is a good thing. What we don't want them to treat, we don't want them to be treated differently, right? We don't want race to be a factor in changing the way we treat these patients. But we know we are treating them differently, unfortunately. And these are a few articles that document these disparities, right? There's disparities, there's disproportionate pain treatment by race, there's disproportionate opioid administration and prescription by race. There's longer length of stay for some populations, like sickle cell disease patients, for example, right? Now, we would think that we will spare the kids. Nope. The kids are also discriminated by race. We think that we spare, the pregnant women. There's discrimination there. We think maybe EMS. No, right? So it's with spread. Okay? So this is the evidence. Let's go into the second case, right? This is me. This is my case. I go into the room, 23-year-old male, sickle cell disease patient. He's there with his wife. I go in, I see the patient. He looks terrible. He tells me that this is his regular sickle cell pain crisis. I'm like, okay, what works for you? He says Dilaudid because morphine does not do anything. I'm like, sure, that's fair. I've heard that before. I go and I present to my attending, and my attending goes, but most of the time they drug seeking, right? I was hurt. I was like, oh my God, I need to sit down. Dr. Perry, do you want to continue? Okay, never mind. So I did not, I was hurt, but I did not let this mess up with my plan. I ordered my medicine, I did my thing. Because pain management is an intriguing intersection between evidence-based medicine and biases, where biases often wins, right? And sickle cell disease is the perfect display of this because despite the evidence of the pain and the disability that this disease causes, we still let our biases run the day, unfortunately. Now, why is that? A few things, right? We underestimate our biases. We are biases, but we underestimate our biases. We have false belief and myth about race and biology. There's a gap in the socioeconomic status between the providers and the patient, and that also leads to language barriers and assumption about cultures, right? So, and this is not on the patient. This is us. This is what we signed up for. So it is for us. It is our responsibility to break that barrier, to bridge that gap, to use interpreters and to educate ourselves on cultural experience and cultural expression of pain. There's a misunderstanding of the nuance between addiction and pseudo-addiction, and this is very, very important, right? Because addiction, we know what it is, but pseudo-addiction is a term that describes when a patient with untreated or improperly managed pain exhibit drug-seeking behavior that is misinterpreted as addiction. It looks the same. You will see the patient fighting with the attending or fighting with the provider, being belligerent, or going from one hospital to the next hospital, and we're like, okay, this is like drug-seeking behavior, but it's just because the patient is in pain. What do they want them to do, right? So they are in pain and they behave this way because they have untreated pain, right? And there's a gap in education. How many of us have had dedicated pain management education throughout our career, right? It is lacking. Again, why? This race is these are the myth, right? Race is a biological construct. Some minorities are more tolerant to pain than others. Darker skin is stronger. The phone test, the sleep test, the food test. When we see our patients in pain, indulging in any normal human function, we assume they're not in pain. But pain patients have to use destructive strategies to cope with their pain. We have colleagues that have diseases, that are sick, that come to the emergency room, right? I was in a PICU. My attending had Crohn's disease, but she's just running with us. She's suffering, but she's just running with us and just going about her day. And even like emergency physician, we have to drop down before we even not show up to our shift, right? So we have patients that deal with pain. Something else, prescribing opioids to black patients might jeopardize my license. These are myths. Now, how do we feel about this? This is a viral post, okay? All right. So these are a few papers that break down these barriers, right? We already talked about pseudo addiction. Contrary to popular belief, and I had to learn this myself. Contrary to popular belief, sickle cell disease is not a risk factor for opioid use disorder. There's no difference in likelihood of developing drug use disorder between sickle cell disease patients and other non-sickle cell disease patients. Another fact is that, I mean, we're all biased against minorities, and even minorities are biased against minorities, right? Now, pop quiz. What is the strongest and most reliable indicator of pain? A patient's self-report. A patient telling me that they're in pain is the most reliable indicator that they're in pain. Now, another one. What does a patient suffering from drug addiction tells me? That they're in pain. So now this is interesting now, right? Because I just said that the most reliable indicator of pain is the patient telling me that they're in pain, but they can lie to me. So this is hard. I don't like that. Now, can I suspect that something is going on, that my patient might be drug seeking? Maybe, yes. But do I know for sure? Likely not. Am I missing the opportunity to treat somebody's pain or somebody's loved one's pain because of the concern of being fooled? I don't want to do that. No. Do I want to withhold adequate pain treatment for my patients because a minority of them may be fooling me? No, I don't want to do that. Because when we do, doesn't that infringe upon collective punishment? Because we're punishing the majority of people because a minority of them might be addicted. This is called collective punishment. So I'd rather be fooled, okay? Because the alternative is depriving somebody from the treatment that they desperately need. Because the ED is likely not the best place to decipher between the two. Now, I know we don't, but what is the impact of untreated or undertreated pain? Undertreatment of acute pain causes chronic pain. So this is another this is another problem, right? Undertreatment of acute pain causes a mistrust in the whole entire system. And when they're back, when they leave, when they don't trust us anymore, we can't get them back. It causes pseudo-addiction that we mentioned. It causes helplessness and then use of illicit drugs. And it costs us a lot of money. A lot more money. Okay? So what can we do? What can we do on an institutional level? We can use care plans, we can use pain protocols, and we can push for pain management education. And I suspect that some people here have care plans and pain protocols at the institution, right? And it's been working, but it's not globalized. Care plans are individualized pain plans in chronic disease patients. The second they hit the emergency room, we send the labs and we start treating their pain. Pain protocols are somewhat similar, but that decreases the time to analgesia, which is a very important factor in pain management. Now, when you talk about pain management education, it's interesting that we don't have dedicated pain management education, while a third of the population of the United States is experiencing chronic pain, and it is the leading cause of disability in the United States. So now, what can we do on an individualized level? We can use phrases like, what is your pain level? What would you like? Would you like something for pain? We can adapt this systemic framework, because as ED physicians, we admit, the framework that we use is we admit until we can prove to ourselves that the patients can go home, right? We can use the same framework IV pain medicine until proven otherwise. That does not mean you get IV pain medicine, you get IV pain medicine, you get IV pain medicine. It is a framework that forces a cognitive process. You pause. It makes you think about how you want to treat that pain medicine. I'm giving IV pain medicine until I can prove to myself that PO can work. Now, the second point is titrate down. We load up front because we don't want to be frustrated at the patient coming back to us, oh, I need more pain medicine, and then everybody gets frustrated. We want to redose within 30 minutes PRN. And we want to document with compassion because documentation is crucial, because documentation can set a patient for failure and for success for life, because people read our notes. We want to be self-aware of our own biases, and we want to think, how would I want my loved one to be treated? We want to educate ourselves and have cultural humility, and use clinical tools when we don't have all the knowledge, right? There's like a sickle cell tool on the ASAP app, for example, that we can use. Now let's talk about case one. Let's redo it, right? That 34-year-old female, she came in a lot of pain. She's telling me all these things. I don't care whether she's black or I'll treat her, right? I ask her the question, what would you like for pain? Or ask her what has worked in the past, because that's probably not her first time, right? I administer the IV pain meds, and then I reassess every 30 minutes. And I will document with compassion and with no judgment. Second case, my sickle cell disease patient, right? By the time, in the perfect world, by the time I see the patient, the lab would have been sent, it would have probably been back, right? I ask the patient what works for them. We give them the protocolized pain medicine, or we give them what has worked for them. And then we reassess every 30 minutes, right? If I'm lost, I can always refer to the tools that we have, okay? And then obviously, making sure we're not missing on all these sickle cell emergencies. Now, to wrap up, let's talk about special mentions, right? A war on addiction should not be a war on taking care of patients in pain, right? Very important point. Higher pain medicine requirement is not an indication of addiction, okay? Some patients need higher level of pain meds. Providers thinking my license might be in jeopardy if I give a prescription to a black person, show that we have criminalized pain medicine when it comes to black patients, but we have medicalized it when it comes to white patients, which is unfortunate, right? Let's not solely focus on diagnosing the pain, on diagnosing the problem, and forget to treat the pain, while it's the pain that brought the patient to the emergency room. They didn't care they were sick in the first place, right? Let's diversify our pain regimen and use a multimodal, right? It's documented that ketorolac, ketamine infusion with some other medications are proven to be safe and effective in pain crisis, for example. Individualized pain treatment achieve faster pain relief for sickle cell disease crisis. Access to pain treatment is a human right, but our societal biases dictate who deserves pain relief. Chronic pain patients go through a lot of hurdles, right? They will have to drag themselves to the emergency room, then relieve their trauma, then we prescribe them medicine, the pharmacist is not giving them the medicine. It's a lot. So let's be the shining, the good part of their whole process, right? And address opioids addiction if you suspect that the patient is going through opioid addiction, and counsel them and give them the necessary services. To conclude, we've shown that there's evidence that there's so much more we can do to achieve adequate pain medicine and equitable pain medicine in the emergency room. We have discussed the impact of undertreated and mistreatment of pain medicine, and we have modeled a framework that can help us navigate this difficult task of treating pain in the emergency room, and so that we can achieve, so that no pain is left behind. So this is the framework. Hopefully that was a helpful message. Hopefully you take this with you in your individual pain medicine and pain emergency departments, and hopefully you gain something from this talk. Thank you. These are my references. Yes.
Question. I know you talked about what we can do on individual levels. Do you have any advice on like how we as medical students can start that and stop us from developing these biases early on?
Yeah, it's like checking ourselves, right? There's one thing, on a personal level, checking ourselves, right? Using that systemic framework, right? IV pain medicine until proven otherwise, right? We're thinking about it, okay, like, I don't care what that patient is. Can this patient get pain relief from pill or IV, right? Just trying to remove that racial aspect and just using systemically these framework all the time. Okay?
I think there's also value as a student, specifically learner, asking for clarification from plans, because when you ask for the reasoning behind pain management plans or workups, you'll be able to see the thought process of your attendings, and that will help you make decisions about your own practice as well, right? It's one thing for someone to say, oh, I think PO will do fine here. It's another thing if you have the opportunity to say, well, when would you use IV medication for X? And then they might give you some answers. And many times the patient, at least from my own experience, the patient would qualify based on their own criteria. So you get a chance to kind of see that bias in action. Right? So that's challenging. It is very, especially when you start moving fast and everything's going on, it's challenging even with those of us that take interest in this and do our best. It's still challenging.
And also advocating for your patients, right? Because sometimes when you're the med student, you see the patient and you present, sometimes it's whatever you say, right? So just advocating for your patients. Sometimes you can see something happening, not even to your patients, but you can advocate, hey, I think that other patients is in pain. Can we give them IV pain medicine, All right? Yes.
In institutions that you've worked in, have you seen instances where they have like a systemic framework as well, where they have individualized care plans for patients who present to the emergency department for pain related to sickle cell or cancer, things that do cause chronic pain?
Yeah, it's very common in peds, right, here. But at Howard, we do have a care plan. At Howard, when sickle cell disease patients come in, we actually sent them to a place, a specific place during the day. During the night, we just use the care plan.
One of my publications is around the EMR for patients. So we did it for the University of Chicago before EPIC. We did it for sickle cell, but it also just tracked visits, and there are several things that would trigger looking at the patient, creating a care plan from visits. And from that, we not only could you streamline care of frequent visitors, we identified abuse because it was cyclical and started to follow the sports, kind of like sports games, led to more visits in the ED and women, for example. So there's a lot of power behind managing the EMR to help navigate that. The other big thing that I've seen, so our own institution at Baylor, in Houston, Texas, so one of the things that we see with our own system is that initially the plan was, hey, by decreasing the resources we give frequent visitors, they'll stop coming. Right? That was part of it, because the idea is of the frequent visitors. And I think what you see very clearly is that their lack of resources is the reason they're coming. So that if you continue to cut off the resources, they just continue to come as well. And documented, although people have not fully instituted everywhere, there are, I can't even say case reports as much as like reports in some of the SAEM Pulse and things like that. But there are places, there was definitely a news article several years ago, I don't know the reference, but they followed 4 frequent visitors, and those 4 to our county program accounted for like 2% of the usage or something ridiculous. And so their intervention was, we bought them a house, we bring them their meds, we help them to get a job, and so we know that. So a lot of the plan, honestly, working with your colleagues and being more cognizant of it, I'm sure you all have received or given sign-out to someone and you're worried, they're not gonna continue the pain plan, they're gonna do something different, or they don't believe them. I think that EMR is a nice tool to advocate for the patient by helping to put that narrative in front of people and then push that narrative forward for others. It's been very interesting.
So the care plan, so I'm Joe Vigus, I'm a nurse specialist at just implementing care plans. And what I would say from the nursing lens is that we all are speaking the same language. So I know what to anticipate as a nurse, like I know that the next meds due, right? And I know what they should and shouldn't receive.
Yeah.
So that's one thing. And then also, how do you advocate or how do you address the nursing staff or the paramedic staff with the bias? Do you, do you stop it, do you see it?
Yeah.
Do you reframe, retrain in real time?
Yeah, yeah. This is actually common, right? And literally, probably last week, I had to. And sometimes you think that it's even minority nurses, right? So it's educating the nurses, right? Saying a lot of people don't know about pseudo addiction, right? And they see the pattern and I'm like, okay, this is pseudo addiction, and I take the time to literally educate them on, okay, this is pseudo addiction. When somebody is not getting pain treatment, this is how they behave the same way as a drug addict. I just go outside of, I take the time to educate them on the individualized level. You know.
I found that, so same piece. So I found that I target total pain medicine rather than dose initially. So you get someone who, I had a nurse win the initial battle recently. It's like, okay, this patient's 100 kilos, they can get 10 of morphine. And then in the chat, I don't know if you all use EMR chat, so in the chat they're like, oh, the patients say they get nauseous when they get anything over 5, so I gave them 4. Like, oh, okay, how'd that come up? Like, okay, can we make sure, well, let's switch to one of the lauded. Oh, the patient prefers morphine. Like, oh, he's winning, it was a him. He's winning today. So what I found is that a lot of times in the moment, the conversation about why, quote unquote, why we need to do better, those sort of things aren't well received. It is better received to say, all right, so my goal is that this person gets 10 to 20 morphine in the next hour and a half. Right? Then you can kind of negotiate around that. If it took a little bit longer, right? I'm not acquiescing, but I'm acknowledging that there are challenges, right? Redosing 4 to 6 to get me to my 16 is more effective than trying to argue for that first 8 and then never getting the second 8. So I find, and then every time I have to do that, you definitely have to follow up and say, oh, they did well. They got 16, they did well, right? And have that conversation. It gets tiring because it's a very one-on-one. And honestly, I had a conversation with a nurse recently. There's a difference between day nurses and night nurses too, right? I feel like the night nurses in general, given some of the things you have to do, lack of resources, they tend to, everybody's nodding, right? So it depends on who it is, where you're at, etc. But I try to negotiate similar volume of drug, essentially, similar dose, but different pathways, rather than trying to get that one large dose. But I know the patient can handle it. So.
Thank you very much.
All right. Thank you.